to one more lecture of pediatrics. As we were discussing the general complaints or general problems in pediatrics, so we are finishing those topics. So one of that topic is enuresis. Enuresis is defined as enuresis. Enuresis. It is defined as in involuntary urinary incontinence. So, incontinence, urinary incontinence, which is involuntary by day or by night in a child who is greater than 5 years of age. We call it as enuresis. So now the point here is that there is something called as toilet training in the childs, and the children, uh, and what I'm talking about in toilet training is about the bladder control because there is bowel control as well. So if we will talk about the toilet training, like if I will talk about bowel control, for example, most babies by age 1 they stop um, passing stools, or they stop pooing, you can say, at night. And by 2 years of age, some children will be dry during the day, but this is still like quite early. By age 3, 9 out of 10 children are usually dry most days. Uh, but we cannot say like they are toilet trained at that time, because all children have the odd accidents, like especially when they are excited, they are upset, they are playing, so they can just forget and they can have accidents. But by 4 years of age, I'm talking about the bowel habits, okay? By 4 years of age, most children are reliable and they are dry during the day. So this is like about the bowel habits I'm talking about. When we talk about the bladder control, the important thing is that most of the babies they have bladder control by 5 years of age, way before that. So of course, like enuresis is lack of bladder control during the day or in the night when the child is like more than 5 years of age. So one thing is called as nocturnal enuresis. Nocturnal enuresis is what, like when the babies they become wet during the night, and that is the most important topic, which is nocturnal enuresis. And because most of the babies we cannot found any cause, so that's why we call it as primary nocturnal enuresis. Then there is something called as diurnal enuresis as well. So there is daytime enuresis as well. So of course, like daytime enuresis is when someone is passing in the daytime. So there could be many reasons, like lack of attention of bladder sensation, as well as there is something called as detrusor muscle instability. Detrusor muscle, which is the muscle of the bladder. So these are the babies, who have a sudden urge to void or run to the toilets. Sometimes there could be bladder and neck weakness. Sometimes there is neuropathic bladder. Bladder is enlarged and fail to empty properly. There could be a UTI. There could be constipation, and so on and so forth. Okay, so there are many reasons behind that. So the important thing here is what, um, when we know that it is the involuntary urinary incontinence by day or by night time in a child of greater than 5 years of age. So of course we cannot say that the child have enuresis if he is not dry by and he is 4 years of age. So how we approach, generally we evaluate if there is any dysuria, change in color, odor, stream, uh, stream of urine, or change in gait. Change in gait, of course, it will tell some neurological problem, or uh, any stool incontinence there as well or not. Okay, so generally, like we go and we evaluate these things, either the baby have this thing or not. Why again? uh, there's something called as primary nocturnal enuresis, and there's something called as secondary enuresis, and there is a third one which is called as diurnal enuresis, right? So what are these? We are going to discuss these three. Okay, so now as I told you, like, there can be many causes related to bladder. Okay, the most important topic is this one, primary nocturnal enuresis. So how we can define primary nocturnal enuresis? Like example, for sure there is nocturnal, so it means like it happened during the night. So simply, this one can be defined as involuntary uh, loss of urine at night. Okay, or and one thing, when why we call it as primary is like when bladder control has never achieved. Okay, so this is an important point. Sorry, yes, I forget to tell about this thing that in this one we don't go for primary and secondary like this way, but we label them as primary or secondary depending on someone who have never attained bladder control or yes. For example, this one. For example, if a child uh, who never been dry during the night time, okay, and now he is more than 5 years of age, so we call that thing as primary nocturnal enuresis. So uh, now secondary enuresis is simply defined as we are going to copy the same thing here. Okay, so we are going to copy the same thing here because in secondary enuresis what's going on is there is involuntary loss of urine at night. Okay, same thing is there, but the child have attained bladder control. Okay, the child have attained the bladder control for more than 6 months. Okay, so how it goes like this, A 4-year child, even if he's not dry during the night, we cannot label them as enuresis. But when the child reached the age of 5, by the way, more than 5, and he was never been dry during the night time, we call this thing as primary nocturnal enuresis. But a child who, for example, attained bladder control, and that bladder control which he attained was at least for 6 months, and after 6 months he again started showing the features of enuresis, we label them as secondary enuresis. Okay, so diurnal enuresis is simply defined as daytime wetting. Okay, okay, this one is like simply, and also wet nights, of course. Okay, wet nights, wet at nights better. Wet nights. Okay, so the thing is, one very 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 important point, which like if, maybe I will forget to mention if I will not mention now. We don't treat uh, uh, we don't treat primary nocturnal enuresis, okay, uh, or should not be considered. This primary nocturnal enuresis treatment should not be considered until 7 years of age. Okay, so anyone who is coming with primary nocturnal enuresis and he is 6 years of age, they like it should not be treated, or it is not treated. But anyone who is coming with primary nocturnal enuresis at more than 7 years of age, he is, for example, 7 years 2 months, then of course we go for the treatment. Okay, so this thing. So you understand, if someone uh, never achieved bladder control, never was dry during the night time, and he is more than 5 years of age, it is called as primary nocturnal enuresis. Whereas someone who has have achieved the bladder control for at least 6 months and they were not dry during the night time, they were dry during the night time, but after 6 months they started bedwetting again during the night time, we call this thing as secondary enuresis, right? So I hope like this thing is clear. So discussing about primary nocturnal enuresis is like enuresis. Okay, as I told you, the definition. Remember, guys, this is more common in boys than girls. Okay, boys are more affected than girls. Okay, so it's like this, that of course, like if you will see a 6 year old, if you will run a study and we will see like how many babies are affected. So around 10% of the babies who reach 6 years of age, they have this condition. And for by the way, the people, like when you like if you will see the prevalence, or like how much common this condition is in 18 years of age of group, we like 1% of people who are 18 years of age, they still have this primary nocturnal enuresis. Okay, so what is the etiology of this thing? I told you many many causes, right? It could be a developmental, or delay, or psychogenic delay, or bladder instability, or neuropathy, or UTIs, or constipation, or ectopic ureter. Like there are many things, many things which can cause enuresis. But like as we are discussing about primary nocturnal enuresis, so basically it is considered as like developmental disorder, or the bladder is not mature enough. Okay, while the babies are sleeping. Okay, so it is more, you can say, it is considered as developmental disorder. Okay, it is considered as a developmental disorder, or you can say maturational lag, okay, in bladder. So this thing, okay. So now this condition is very much disturbing, by the way. Why? Because the babies, when they wet the bed, basically the caregiver or the mothers, most like, because mothers are the most of the time they are the caregivers. They have to change everything, they have to clean everything, they have to uh, do a lot of work, to handle these things and wash the clothes, what the beddings and all this stuff. So it is quite disturbing. So when you will find the parents, who will bring the children with primary nocturnal enuresis or enuresis simply, you will find them too much frustrated, too much worried, because uh, they they are dealing with this thing, right? So uh, whenever we manage, or whenever we know that the baby is suffering from primary nocturnal enuresis, so first of all we reassure the parents that what kind of condition it is, okay, and we tell them that most of the babies, they resolve themselves, okay, or simply you can say 20% of the babies they resolve spontaneously each year, right? So there are high chances that if someone is 5.5 years of age and he's still wetting the bed during the night time, so maybe like after 1 year, there is a lot of chances that he will not wet the bed, and after 2 years, of course, the chances will increase even more, right? So these things, like, we reassure them, mm, we explain the nature of the condition, we of course show them empathy. We tell them that we understand, like, this is a hard time, and like they are dealing with like too much, uh, because whenever the babies of course wet the bed, so they have to change everything, they have to clean and everything, okay. So you have to reassure, you have to tell the timeline when this kind of condition will be resolved and stuff like this. And then we ask them for some behavior modification, okay. Behavior modifications can be done. So what is the behavior modification we can do is like, for example, if you will drink a lot of water, you have to go to the toilets again and again, and because your bladder is working fine and you have good control, so of course either you keep on sleeping, or whenever like you wake up and you are feeling like your bladder is going to burst, then you run for the toilets, right? So we can ask them to limit fluids after evening time, right? Why? Because near the bedtime, don't give enough fluids, because like too much fluids, because they are going to urinate more, and there is increased chances that they are going to wet the bed. And one very good technique is like uh, void during sorry, not during, before sleeping, okay. So we always tell them that take the babies to the washroom, toilet, okay, and ask them to pee before going to the bed, okay. So of course, like, this thing can be done. Bladder retention exercises are there, but babies, they are not so comfortable, like they are going to uh, you can say cooperate with the person who is asking them to do so. So of course, like, they are not so helpful in them. So of course, like, the many exercises are there, okay. One of the thing which is quite interesting is like something called as uh, wet alarms, like this is something called as wet alarms, okay. Now if you remember, the experiments which were run by the Pavlov, like, if many of you don't know, like, they teach us in pre-medicine, like, or in our A levels, that there is a guy Pavlov who did experiment. What he did, like, whenever he wanted to give food to the dogs, he usually ring the bell, and then he put the food in front of the dog, okay, and he keep on doing this thing. And what he found, like, after doing so that things for so many days or so much long time, After that, whenever like he ring the bell, and even if he don't give food to the dogs, what happened, like their saliva basically started coming out. Okay, so this is called as conditioning reflex, right? So what is conditioning reflex? Like you are associating the food with the bell, and now when you ring the bell, now they know the food is coming. So like of course their salivary secretion started making saliva, and like all these things are under autonomic control of the body. So wet alarm is type of a conditioning, uh, what you can say, conditioning reflex, right? So we condition them, we try to associate this thing with them. So it have a high success rate, by the way, around 70 to 75% of success rate. These alarms are available from the market, and what it do, uh, as soon as like the child, he lose the bladder control and the urine start uh, dripping down, and it touch the that that alarm sheet, right, which is under him. They started ringing bell. So as soon as it rings the bell, the child wake up, and what he do, like he turn off the alarm, and he go to the washroom, or take him to the washroom, toilet, okay, and ask him to void or urinate, whatever, okay, or micturate. So this is a type of a conditioning type of reflex, and by trying this thing, um, many of the children, they respond to this thing. Okay, it have good response rate. So wet alarms can be used, and then of course the medications are there. And what kind of medications are there? But medications are not considered as what you can say the first line therapy. Okay, rather they are considered as a second line therapy. Okay, for the babies. So what kind of medications are there? One very important medication is uh, DDAVP. Okay, so now what is this DDAVP again? Uh, DDAVP is basically uh, anti diuretic hormone. Okay, so it is basically anti diuretic hormone, DDAVP, or you can also say desmopressin. Okay, desmopressin. So if you know what is the function of antidiuretic hormone, uh, or what is the function of desmopressin, what it does, like uh, this desmopressin or DDAVP uh, acts, or you can say acts as the replacement of antidiuretic hormone. So what happens, like whenever we give DDAVP, so there is antidiuretic hormone, which comes out from the posterior pituitary, and as you know, what is the function of antidiuretic hormone? It prevents that diuresis. So of course, like there is less urine formation, and there is less urination. So DDAVP can be used, or desmopressin can be used. So of course, like how they give is like it can be given by inhaler forms and stuff like this. So DDAVP can be used, and uh, nowadays of course not, but like when I was working in my country, so I have these things, like they seen this thing, like any baby who used to come to our professor, so they used to give them imipramine. Okay, so what is imipramine? Which is basically uh, it comes by the name of tofranil. It comes like uh, I think worldwide it comes by the same name. Okay, uh, by the name of tofranil. So imipramine is basically uh, it's a DCA, tricyclic antidepressant, right? So there is something called as off license use. So you can say it's an off license use for such a drug, right? So it is used as a treatment for nocturnal enuresis. Okay, so why it is used as a what you can say for nocturnal enuresis? Because of its cholinergic side effects. Okay, so cholinergic side effects, what are they? Uh, if you don't know, like very important because all the antipsychotic medication have the same, what you can say, side effects. Okay, so it like one of the cholinergic side effect is urinary retention. Okay, so whenever we give tofranil, imipramine, there is urinary retention. So of course, there are other symptoms, cholinergic symptoms as well, but like we give tofranil or rarely used nowadays, not used much. Okay, but rather I should write over here, rarely used. Okay, why? Because tricyclic antidepressants have a lot of side effects. Okay, and of course, like it can cause poisoning, like if taken as overdosage. So that's why it's not a good point to use this one. Then there is secondary enuresis. So what is happening in secondary enuresis is, like, of course, they had achieved the bladder control for at least 6 months. Okay, and then they lose it again. So of course, like in this one, we there could be a lot of causes. Okay, it is, you can say in this one that it is always secondary to something. Okay, the most common reason of this type of secondary causes is stress or anxiety. Okay, we all think like the children that they are not stressed out or they don't have anxiety, but they do have. And they for example, children, they observe everything, they take stress and all this stuff. Okay, sometime like when they lose something which is important to them, sometime when the condition of the family is not good, everyone, for example, one parent or the parents don't have good relations, so all these things have effect on the children. So you can say this stress or anxiety, because of this stress and anxiety, they show regression behavior. Okay, they show regression behavior. It's a very important cause. Or there could be UTI, there could be diabetes mellitus, there could be diabetes insipidus, or there could be neurogenic. I think I discussed all these things before, right? Neurogenic bladder, or there could be subdevelopmental problem like cerebral palsy, and so on and so forth. So, of course, one of the causes of a secondary neurosis, like which is again linked to stress and anxiety. For example, the birth of the newborn baby, right? So when the soul show this see this thing that the newborn baby is getting more attention, they show this regression behavior. Okay, they throw more tantrums and things like this. So how we treat this thing is like to treat the underlying cause, of course. Like all these causes which are right over there, we have to treat them. So then there is diurnal enuresis, and again this one is as the name shows, daytime and nighttime wetting both, right? Both are there. So etiology of this one could be many, but one of the thing is called as micturition deferral. Okay, what is micturition deferral? The children the children, they keep on holding their urine when they are busy playing something, so they don't go to the washroom until the last minute is reached. And when the last minute is reached, what they do, they just run to the washrooms. Okay, and when they rush to the washrooms, of course, like either they rush or either they lose right away. So of course, like this is one of the cause for enuresis or diurnal enuresis. Okay, so these are the causes, like this is one of the cause for what you can say this enuresis. Other causes of this diurnal enuresis can be again, uh, for example, some anatomical uh, abnormalities. Okay, for example, ectopic urethral site or neurogenic bladder. It could be UTI. It could be constipation. Okay, and it could be CP or any neurological deficit. It could be diabetes mellitus. Guys, see, remember diabetes insipidus, diabetes mellitus. See, these are the conditions in which there is like more and like people go to have more urination than normal. And why constipation can give encouraces or like involuntary urine come out is simply when you strain out to poo for sure, like what happens is like in these babies they have the same thing, like the urine come out, okay, while either maybe they are holding, trying to hold their feces or anything like this. So all these things are the causes for um, diurnal enuresis, right? So this thing now, what is the management for this one? Again, treat the underlying cause, okay? Of course, like this one is important. So basically, treat the underlying cause plus toilet training is very important, guys. Okay, toilet training is very important. There is something called as good bowel program, or charting can be done. Okay, uh, incentive program can be run for the babies. For example, you can put a chart and you must give a star or something rewarding thing, on the chart when the child is performing well and he's not having this thing. Okay, so a lot of things can be done, to train the babies in a good way. So this thing is like all about encopresis. Then there is a topic called as encopresis. Encopresis. Okay, so as enuresis was about the urinary problem, but encopresis is basically defined as fecal incontinence. Okay, when the child they soil their clothes, okay, by feces, fecal incontinence uh, in child who is greater than 4 years of age. And by the way, this age groups are very important to remember. Okay, in a child, in child greater than 4 years of age, and they must doing this at least once per month. Okay, for 3 months. Okay, so of course, like if some child have soiled his clothes by one, like on one occasion, and he have never done after that, of course you cannot label them with that copresses. But like you can label them anyone within copresses when they have like at least one time month for 3 months. Okay, so then we can say that the child have encopresis, because one episode or one mishaps are easy to happen, you can say. So same thing which I was telling you about the toilet training things, in the start, how I started my story is like, how they are toilet trained or bowel controls can achieve. Now, by the age 4, most children are reliably dry, okay, during the daytime. So, of course, like, we must not be very strict with the children to potty train them. Rather, we must be a little lenient, okay? So, don't force your child to use potty. And most child will not want to go to school in nappies anymore, of course, like because they will try to learn themselves at that time. And many of the parents, they start planning or they start training their babies around 2 and a half years of age. Okay, but there is no perfect time because every child is different. There are children who can be potty trained at 2 years of age, but there are child who can never be potty trained at 2 years of age. Rather, maybe at three and a half or like this, right? So this thing. So we must always potty train them when they have no great changes in their life. Okay, because it should be consistent. You must be consistent and you must do that thing, every day, and teach them what to do and take them to the potty and tell them that, because the parents have to wait a lot. Okay, and one day, of course, like they understand, where they have to pee and poo. Same like when you have some pet animals, they learn how what to do. So children, they are fast learners. So like this way, what you can say, there's a lot of training, guys, like on these things, because I have a personal experience as well, so I can talk a lot about that. So Basically 90% of the children they attend bladder control um, before bowel controls, okay. And generally, by the way, very important thing, uh, females train earlier than males, okay. Or simply like girls, they learn quicker than boys, okay. So like by 3 or 3.5 years of age, you will find most of the babies they are potty trained, okay. Maybe they're still wearing nappies, because the parents are always scared that they can throw that beautiful thing anywhere, so like they keep them in nappies, of course. So like there are many factors, what you can say, which play a role. Like there are some of the signs they say, like which shows like the child is ready for potty training. For example, when the child can move independently, okay. uh, when the child is able to sit stably, okay. For example, if the child who cannot sit stable on a chair, so how he can still sit still on his potty, of course, hard, okay. So for example, someone yeah, one very important thing, for example, when they have uh, sufficient what you can say, uh, expressive or receptive skills, like they are following two stage command. Again, that's a very 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 important sign, that they are ready. So this thing, okay, like these are the few things, uh, so um, and other things, like if you're noticing that child, he have like he's wet or he's dry for many hours, okay. Like all these things, so there are many things I like, uh, of course we can talk about those things, for a longer time, but so definition I told you guys. And like females, if they train earlier than males, so most like, of course, common sense says that you will find more boys than females with this problem. So you can say boys to girl ratio or male to female ratio is 6:1, okay. So very common in males. So now one thing is called as retentive encopresis, okay. That is caused by chronic, rather I will say, what are the causes of encopresis? Many of the babies, they have chronic constipation, okay. And that's the reason they have this encopresis. We call this thing as retentive encopresis, okay. uh, or there could be like other causes of encopresis could be diseases like hypothyroidism, okay. Like Hirschsprung disease, Hirschsprung disease, okay. Like bowel obstruction. So there are many 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 causes, okay. Or anorectal problems, or hypercalcemia, or spinal cord problems, okay. So there are many many causes for encopresis, right? So like I told you, primary nocturnal endometriosis is very important, that there here retentive encopresis is one of a very important topic. So that's why we are going to talk about retentive encopresis, right? Now retentive encopresis by definition is what happens. I will explain you in this way, then I will start writing down. Basically, these children, due to some bad experiences, one of the bad experience can be if, for example, the parents are trying very harsh ways to potty train them, or for example, the child is scared or afraid to go to the toilets. There could be many reasons. Uh, a very common example of that thing which I would like to mention here is what? For example, if the child is taking a diet which is not enough in fibers, and when the child is taking such diet which is not enough in fibers, what will happen is child is going to develop constipation, right? Now, due to constipation, uh, when the child goes to the toilet, they will try to strain out. And when they try to strain out, they feel pain. And sometimes when they try to strain and they pass a big dry stool, there could be fissure, okay, which is quite painful. Now, when the child have this pain while passing stool, basically they get scared, and they don't want to go to washrooms like toilet again, and they try to hold their feces. And when they try to hold their feces, the feces, they become bigger and bigger in size, okay, and harder as well. So you can say they have fecal material inside, in their rectum, which is collected. So due to that, what happens, the other stool material, which is, you can say, semi liquid, or sorry, semi solid or liquid, which is blocked from these blocks of stool which are still inside. Sometime there is a seepage of that, okay, and when there is seepage of that inside the rectum, there is overflowing, okay, or it flows out from that. So this is how this thing happens, okay. So we call that thing as overflow incontinence as well, okay. I would like to show you. I think we can, if I can found any good diagram for that. I think like we can I can show you a photograph, or like just to explain you how it goes. um, just we have to wait, okay. So now, what happens, guys, in this one is, okay, yes, there is. I would rather show you here, right? So what we can do is, there's a screen recording going on, okay. Okay, so as like I'm taking out that photograph out, what we can discuss is, what we can discuss. Okay, yes, it's already there. Okay, so if you will see this one, um, if you will see this one, see what happens. Like there is too much stools here collected over here, right? Big blobs of stool are collected over here. So all the liquidy stool which will collect over here, sometime it will leaks from the side, and it will soil their clothes, right? So we call this thing as retentive encopresis. Maybe, yeah, this one is like again a good diagram to see. So see, all this thing is blocked, and all the liquid which is collected over here, they can leak out from the side. So retentive encopresis is simply defined as, uh, like a child holds bowel movement, right? Due to any fear, which I told you, they develops constipation. Okay, once they develop constipation, it leads to fecal impaction, okay, which on examination you can feel by your hands, and on x-ray you can see that there is big masses in the colon. So leads to fecal impaction and seepage of soft or liquid stool, right? Which is like also called as overflow incontinence. Okay. So what is the etiology? It could be anything like painful defecation, okay, as I told you, or constipation, okay. Of course, like, okay, or you can say painful defecation due to or secondary to constipation, okay. So one of the cause, or again, emotionally disturbed child, disturbed okay, can occur, or social stressors and things like this. So all these things can occur. So Now, if you know that posture when some a baby, especially, they wanted to go to toilet but they are not going, you will found that they cross their legs or stand on their toes because they want to resist the urge to defecate, right? So uh, when you will ask on the history, maybe you will found this thing, cross leg behavior, and you will find a history of soiling of the clothes, uh, and you will find like sometimes there is abdominal pain as well. So like when we examine the baby, sometimes we can feel the hard stool masses, okay, in the rectum, okay. Again, one thing which we do is called as, if DRE, which is digital rectal examination, okay. And maybe you will, when you will examine their anal region, what you will found is anal fissures, okay, and that's the reason they are not going to the toilets, okay, or they are scared to go to the toilets, okay. So anal fissures maybe you can found in these babies, right? So so where you can feel the heart stool is in the left lower quadrant, okay, left lower quadrant, opposite to appendix simply. And DRE, as I told you, digital rectal examination can be done in this one. Okay, so what is the management of this one? Management of this condition is very, very important to know. Okay, now what you can say, uh, there are different type of laxatives, guys, okay, available in the market. So one of few of them, I will name them. So there is something called as okay. So first of all, what is the management plan? See what's inside. Our first management goal is to clean the bowel, right? So uh, clean clean the hard feces which are still inside. So clean the bowel is the first and the most important step. So for this one, you can give many drugs. One of the drug which is given to the babies is called as PEG 3350. Okay, so what is PEG 3350? It is basically polyethylene glycol 3350. It's a laxative solution that increases the amount of water in the intestinal tract, and which of course stimulate the bowel movements. So it is used as a laxative, right? So what we do, we give these babies this laxative orally, okay. And what will happen, of course, it is going to increase the intestinal water content, and it is going to act as a laxatives, okay. So this one can be given, of course you can give enemas, or you can give suppositories, okay. Like whenever babies have constipation, we use suppositories, but like these are the second lines. This is the best drug which we can give. Polyethylene glycol 3350 is the best one, okay. So see, when you will give them, what will happen, the hard stools are going to come out. Now, guys, the problem is this thing that, as it's a chronic condition, and due to its chronicity, and due to increased level of that hard masses of stool are still inside, or like they stay inside for a long period of time, what happens is like their you can say bowel become too much dilated, okay, due to holding those feces for a long period of time. So once you have once the intestine or the bowel is clean, okay, so make sure to uh, keep it clean, okay, for a little long period of time. So how we can do that? We have to maintain regular bowel movements, okay. So what can be done? See, a lot of, you can say, parents or guardians, the one who is guarding the, you can say, training or education, you can say, is needed in this regard. So what is done, what we can say, what we can tell the parents that, number one, um, put them on toilet, okay, put them on toilet uh, after every meal, okay, change their diet to more fluids with a lot of fiber diet, okay, very important. A lot of fiber diet can be given to these babies, okay. This thing, uh, any if there is any psychosocial stressor, so what you can say, treat that. So we tell them that, that there was big stool pieces which we have already evacuated. Now what you have to do is like to maintain this one for a little long period of time, okay. And that's the important thing. We have to give them more fibers. We have to give them the bowel habits, like they have to empty sorry, the bowel habits. They have to empty their bowel, regularly, so that, there should be no constipation and there should be no pain again. So like this is the thing how we deal these patients. So a lot of behavioral modification is needed, because sometimes when the colon becomes so big, we call it as toxic megacolon, okay, that requires 3 to 12 months to treat. Sometimes it can perforate, which is a dangerous complication, okay. So thank you guys, that's all about encopresis and enuresis, and I'll see you in like next lecture.